Hello, it is my pleasure to now introduce Dr. David Mount. David is one of my colleagues here at the Brigham, and I expect to learn an enormous amount from his lecture, as I always do. David's from University of Toronto Medical School. He did his residency at Toronto General and his fellowship here at the Brigham. He is the associate and clinical chief at the Renal Brigham and Women's, and he's co-director of the glomerular disease clinic at the Brigham. He's also the director of dialysis services and an incredibly active clinician and researchist. Thank you, David, for speaking with us today.
Thank you, Alice. So here are my disclosures. So just to give a quick overview, I'm going to cover both hyponatremia and hypernatremia. Depending on time, we may cut short the hypernatremia section, but it's here for educational purposes. We'll talk about the pathophysiology and the diagnostic approach, the clinical sequelae and management, and the same basically for hypernatremia. So one key principle is that vasopressin or AVP or ADH, antidiuretic hormone, regulates water homeostasis and osmolality. Classically, textbooks show this slightly inaccurate picture showing that thirst increases slightly to the right of vasopressin in relation to osmolality. In reality, it seems like they're actually concomitant and track pretty well. So if you have a water excess, plasma osmolality decreases, plasma vasopressin declines, and you increase water excretion, and so on and so forth. And this terrific scheme from Jeff Sands, I've not changed for more than 20 years now. But it sort of underlines the fact that the renal concentrating mechanism really involves several tubular segments. So in the descending thin limb, aquaporin 1 plays a big role in passive water absorption that increases tubular sodium chloride. And then a transcellular chloride channel, CLCK1, plays a big role in passive salt transport in the ascending thin limb. And then in the ascending thick limb, that's the countercurrent multiplier for renal concentrating mechanism through the NAKCl cotransporter and the ROMK channel. Urea is absorbed along the nephron, but primarily in the medullary collecting duct, and plays a big role in allowing us to concentrate the urine in the setting of high protein intake. And then aquaporin 2 and 3 and 2 and 4 play a big role in water transport within the collecting duct. And if you knock out any of these pathways, you'll see a defect in concentrating defect. For example, aquaporin 1 knockouts have a pretty prominent nephrogenic DI. The final common pathway, though, is really the collecting duct principal cells and connecting tubule principal cells, where the V2 receptor turns on cyclic AMP generation that turns on protein kinase A, and through that influence makes aquaporin 2 and phosphorylated aquaporin 2 shuttle to the apical membrane. And then water is reabsorbed down the concentrating gradient through the basolateral water channels, aquaporin 3 and aquaporin 4. So this is, for the most part, involved in many of the syndromes of hypernatremia and hyponatremia. For hyponatremia, perhaps the one exception is low solute hyponatremia, where vasopressin probably doesn't play an important role. Why is this relevant? Well, we can now start to play with this. There's a drug, fluconazole, and there's a group in Europe that has sort of a slow-moving clinical trial on using fluconazole for nephrogenic DI. It increases aquaporin 2 phosphorylated abundance and decreases ubiquitination, and can overcome deficits in nephrogenic DI. But I encourage you to pull up this paper, which is now from the prior decade. This table from Bud Rose's many textbooks in the 80s and 90s has always been very useful for me because it sort of settles out these competing systems for osmoregulation and volume regulation. In osmoregulation, you sense plasma osmolality, whereas in volume regulation, you're sensing arterial perfusion pressure, or what we used to call effective circulating volume. Hypothalamic osmoreceptors play a big role in sensing osmolality, whereas there are many different pressure sensors in the carotid sinus, afferent arteriole of the kidney, and atria. The effectors for osmoregulation are vasopressin and thirst, whereas there are a number of different effectors to regulate arterial perfusion pressure, including the sympathetic nervous system, the renin-angiotensin-aldosterone system, ANP and BNP, but also vasopressin. And here's where it gets complicated, because there are disorders in volume regulation and arterial perfusion pressure where vasopressin is activated and can cause hyponatremia, and that can be confusing for trainees and physicians alike. And then we affect urine osmolality and water intake and urine sodium excretion, and also vasoconstriction by these different systemic systems. So there's hypothalamic control of vasopressin secretion. There are osmoreceptors in the OVLT and subfornical organ that project down to the paraventricular nucleus and supraoptic nucleus. And then that's where vasopressin is synthesized and released from the posterior lobe of the pituitary. This is not a static relationship. The curve in terms of vasopressin release related to plasma osmolality can be regulated based on volume status. And these were papers from the 80s when there was an RAA finally for vasopressin. If you make a subject hypovolemic, the vasopressin starts to show up at an osmolality of about 270 and has a steeper response curve. However, if you salt load somebody and make them hypervolemic, you press it to the right. This curve also changes in many different disorders. It changes in heart failure. It changes in pregnancy. And you can move between these curves. If you're hypovolemic and you're given fluid, probably through the mediator angiotensin 2 within the brain, you'll switch to the euvolemic curve, and vasopressin will go away, and you'll get a water diuresis. So this really happens under minute-to-minute basis to some degree. And vasopressin has a very short half-life of about 10 minutes. So this physiology always changes in our hyponatremic patients based on what we do to them. And again, as I said, thirst is stimulated over the same range of osmolality as AVP via activation of central osmoreceptors. And you typically need intake of water to generate hyponatremia. A corollary is that in SIDH, this paper doesn't get referenced enough, but it's a very careful study of thirst in SIDH patients. And as you might expect, with SIDH, which is in many patients a central disorder of osmoreceptor neurons, thirst is also shifted to the left. So how do we initially evaluate hyponatremia? Well, clearly we need to do an H&P and look for medications. SSRIs and anything that regulates serotonin are the most common contemporary cause of SIDH in my experience. Serotonin activates osmoreceptor neurons, so anything that turns on serotonin tends to turn on SIDH. You need to know what's happened in the past. For example, is this a patient that's had prior pituitary surgery? You need to look for symptoms that you can attribute to acute or chronic hyponatremia, and symptoms that are suggestive of a cause. So if somebody's had profuse diarrhea for several days, you know that this is probably a contributory issue. And you're always trying to sort out, is this acute hyponatremia or chronic, which is defined, as we'll show, as greater than 48 hours. Every April at the Boston Marathon, all the downtown emergency rooms get many patients with acute exercise-associated hyponatremia, where it's very clearly an acute issue. Most of the time, though, it's a little bit less clear-cut. Then you need a volume exam. Is this a patient that's hypovolemic, and checking orthostatics and looking at their JVP, or do they have an elevated JVP edema with chest and inspiratory rales that suggest they're hypovolemic with pulmonary edema? You need a plasma osmolality. It's with low, it's high osmolality. It's true hypotonic hyponatremia. If it's normal or elevated, it's pseudo hyponatremia or renal failure. Urine osmolality is extremely important. If it's less than 100, this is somebody who's got primary polydipsia and is undergoing a water diuresis, or they may have had hypovolemic hyponatremia and now their vasopressin's gone away and they're starting to have a water deficit. Greater than 100 milliosmoles per kilo suggests reduced water excretion. People that are in between, if you go back to the bedside, somebody with a urine osm of 300, say, chances are they have some degree of excess water intake as well as a cause for SIDH or other cause of hyponatremia. The urine sodium excretion is concentrations and critical. If it's less than 20 or so, maybe a little bit higher than that for an elderly patient, you think of effective volume depletion. Either they're hypovolemic, clearly hypovolemic, or they have a hypervolemic cause of hyponatremia. Greater than 20 suggests a euvolemic cause or renal salt wasting. So we have a patient, this is a case we had many years ago at the Boston VA, relapsed alcoholic, drank 12 beers a day, had been to his PCP 2 days before, was found to have a serum sodium of 115 and told to return to the ED. On exam, he's barely rousable, but responds to command slowly. Supine blood pressure was 124/67 with a heart rate of 80. Standing, he was actually initially hypertensive, but then hypotensive after 5 minutes. His serum sodium was reported at the VA as unmeasurable and less than 110. He had a low chloride. Serum osm was 236, extremely low, and a urine osm of 226 with a urine sodium less than 20. And again, this isn't a made-up case. This was a case we saw many years ago. So which of the following is the most likely cause of this presentation? And you can use the audience participation to answer this. And it looks like, as I would expect, people are toggling between the first two choices. This is a patient who's existing on beer, but he also has a low urine sodium and he seems like he's hypovolemic. And, you know, I chose this case because it really shows quite dramatically that you can't always discern the exact cause. And I would argue that it doesn't really change your acute management because both causes of hyponatremia are likely to overcorrect. And we'll talk about that in a bit. So this was, though, probably low solute hyponatremia or beer potomania. And as he woke up, he started to admit to increasing amounts of beer, such that 2 to 3 days into his admission, he did mention that he drank what I used to call in Canada 2-4 of beer. So 24 bottles of beer a day. So here he has a history of alcohol dependence with suspicion of recent drinking. He had low urine osms, but not profoundly low. He had a rapid initial correction with IV saline, seemed euvolemic, but his orthostatics were confusing. And as I said, the management would be similar for hypovolemic hyponatremia to avoid a rapid saline or solute intake. So beer potomania is thought to be a vasopressin-independent cause of hyponatremia. You need some minimum amount of solute in the urine to excrete free water. So beer provides carbohydrates that can sustain caloric intake, but there's really no salt or protein, and it generates minimal urinary solute excretion. That's combined with a high free water intake from the beer, and patients become hyponatremic. I like to joke that there's no vodka potomania. You can't drink 2 liters a day of vodka and still remain standing, but you can drink many, many beers and do okay. Classically, there's a low urine sodium and a low osm, but it can be generous. In this case series from several years ago now, suggested that many of these patients have pretty generous urine osms. If you see at the bottom, there's a urine osm of 338 and 340, and it's not always consistently reported, but it's really the clinical scenario combined with a lowish urine sodium content and a low urine osm that clues you into beer potomania. This nice review from Tom Burrell shows that this relationship that if your daily solute excretion is the 300 milliosms per day, you really can't clear free water. And therefore, as you increase your free water, if you're drinking nothing but beer, you then develop hyponatremia. If you then you start eating or given solute, you can suddenly have this rapid water diuresis and overcorrect your sodium. So further testing, TSH is helpful to rule out hypothyroidism. You need a random cortisol to look for primary or secondary adrenal failure. You may need to check other indices of pituitary function if hypopit is likely. So endogenous circulating glucocorticoids suppress vasopressin. So if there's no glucocorticoids around, you get basically an SIDH picture in secondary hypopit, secondary adrenal failure, and so on and so forth. I generally recommend doing a chest CT in patients that have a smoking history or anybody with a high likelihood of small cell lung cancer. You can miss a central lesion with just a chest X-ray. And a head CT is helpful if you find no cause for SIDH. We had a case several years ago of olfactory neuroblastoma in a pregnant woman with SIDH, where that was picked up on a head CT. And I think you're all familiar with this tripartite diagnostic tree for hyponatremia. With hypovolemia, your total body sodium is decreased, but total body water is proportionately increased, but potentially low. SIDH is considered to be euvolemic, but in reality is slightly hypervolemic. And hypervolemic hyponatremia, such as in heart failure and cirrhosis, has an increase in total body sodium and total body water. And you're all familiar with the use of the urine sodium to further distinguish these possibilities. And again, so if your urine sodium is less than 20, and you clearly got, say extra renal losses, you've got hypovolemic hyponatremia. So the urine sodium is extremely important in this. For hypervolemic hyponatremia, you're defending the circulatory integrity in the setting of a decreased cardiac output for heart failure and other causes. And that can be either hypovolemia or low output heart failure, or a decreased oncotic pressure and increased capillary permeability that decreases your cardiac output, and that turns on non-osmotic vasopressin stimulation, as well as these other mediators that I mentioned, and you get renal water retention. You then preserve your arterial circulatory integrity, but as bypass, you have hyponatremia. You can also see this in vasodilatory states, classically in cirrhosis, where again, you activate the same set of mediators and develop hyponatremia. So where does this urine sodium of less than 20 come from? A lot of it comes from this single paper from Denver many, many years ago, where patients were judged by two expert clinicians to be euvolemic. And then they gave them, I think, 2 liters of saline, and they looked at the response. The saline responders who had hypovolemic hyponatremia, they had urine sodiums with a median of 18, whereas those who did not respond and had SIDH had much higher median urine sodiums. I think you're all familiar with the differential for SIDH, that drugs are an important cause, pulmonary disorders, tumors. Maybe 75% of tumor-associated SIDH is small cell lung cancer. CNS disorders we tend to sometimes forget about. And then there are miscellaneous causes, prolonged exercise, for example, HIV infection, and so on. There is controversially an idiopathic SIDH that can be detected in elderly patients. But that needs to have an extensive workup, including a chest CT and head CT, to make sure we're not missing some structural cause of hyponatremia. Many years ago, Robertson looked at these different patterns of SIDH. The first pattern was all over the place, this unregulated, erratic vasopressin release that had no relationship to osmolality. There is a baseline increase with a normal osmotic response. And then type C is the reset osmostat. And then there's a subset of patients with suppressed AVP. That may show up on your board exam because one of the causes of that is what's called the nephrogenic SIDH, where there's a single point mutation in the V2 receptor that activates the AVP receptor and can cause hyponatremia even in unexpectedly older patients. So here's an easy question again. A 19-year-old woman is brought to the emergency department with altered mental status. She'd been at a rave the night before, became drowsy at around 2 a.m. and vomited several times. At 4 a.m., she had a generalized seizure that lasted around 15 seconds. On exam, she's unresponsive. She's now intubated and ventilated. And she's got a very low serum sodium, but not profoundly low. And she does have hypotonic hyponatremia with an OSM of 242. So which of the following is the most likely cause of this syndrome? Ecstasy-induced hyponatremia, hyponatremia secondary to a seizure, exercise-associated hyponatremia, acute intracerebral bleed, and compulsive drinking. So based on the solid green line of about 100% for ecstasy-induced hyponatremia, that seems to be the leading cause. So ecstasy is basically SIDH in a pill. This is volunteers who took a single tablet of ecstasy, and you can see this screaming increase in their vasopressin level immediately afterwards. So it's due to a combination of factors. You get this acute massive increase in AVP. Serotonin activates central osmoreceptors. So if you look at CFOS staining in the brain as a marker of activation, the osmoreceptors get turned on dramatically, but as does the rest of the brain. So it's not selective. And that increases AVP response from the posterior pituitary. There is also acute stimulation of thirst because serotonin activates these central osmoreceptors. And there are cases where people came in with an overdose of ecstasy and immediately started drinking a profound amount and became hyponatremic. Historically, subjects were told to deliberately increase their water intake. I don't know if that's a common problem anymore because there was some degree of concern about hyperthermia and rhabdo. But this segues into acute hyponatremia, and it's important to separate this out because there is a separatable differential diagnosis. Classically, this was seen in postoperative settings, particularly in premenopausal women who were given hypotonic fluids after, for example, ovarian surgery and would acutely seize because of acute hyponatremia from the surgical procedure. Any hypotonic fluids with a cause of increased vasopressin can do it. Glycine irrigant can also do it, like in TURPs and uterine surgery. You can see it after colonoscopy preparation, and you can develop hyponatremia within 24 hours of taking a thiazide. Polydipsia can do it, ecstasy ingestion, exercise-induced hyponatremia. There's an increase in IL-6 in marathon runners that's thought to play a role. Or it can be multifactorial. As patients on a thiazide and they're polydipsic, they might be hypokalemic as well. But there is a separate set of causes for acute hyponatremia. Classically, you can develop these symptoms over time. Early on, headache, nausea, and vomiting are very prominent symptoms. Later on, they can get asterixis, obtundation, incontinence. You can get seizures, decorticate and decerebrate posturing. Afterwards, these patients can have a polyuria from a central DI or a type of diabetes with hyperglycemia. The problem, though, is people don't really have a nice orderly presentation. I've had patients come into the ED with exercise-associated hyponatremia and headache, nausea, and vomiting, and then seem stable and then suddenly have a seizure 2 or 3 hours later. Interestingly, there's a female preponderance in acute hyponatremic brain injury. The incidence of hyponatremia isn't any different, or largely not that much different between men and women, but the cases of acute hyponatremic brain damage are almost exclusively seen in females for reasons that aren't entirely clear. This is a case of a marathon runner coming in with pulmonary edema, which is another important sequela of acute hyponatremia. And you can see the CT head with massive cerebral edema. And with resolution of the hyponatremia, the chest X-ray cleared up, as did the brain MRI. This is a fatal case of ecstasy-associated hyponatremia with florid pulmonary edema. So thinking, though, of chronic hyponatremia, if we switch gears, this is after greater than 48 hours or of unknown duration. There's a CNS response to hyponatremia that induces sensitivity to the correction rate with respect to osmotic demyelination syndrome. And we'll talk a little bit about how that happens without going into the molecular details too much. However, many generations of med students have been taught that the symptoms in chronic hyponatremia are absent, but they may include nausea and vomiting. They may have muscle cramps and weakness. They may have ataxia and they may fall. They can have confusion, change in mental status. Observe that patient who clearly had chronic hyponatremia from his beer potomania, who is obtunded, and they can get seizures. Physiologically, you get a water gain with acute hyponatremia. You get what the rapid volume regulatory response, where you lose sodium, potassium, and chloride from inside cells. And then you lose organic osmolytes from brain cells. And unfortunately, the regain of those osmotic osmolytes is much slower than the loss. And if you have improper therapy and a rapid correction of the hypotonic state, you can get osmotic demyelination. So this is what you don't want your MRI of your patient to show, which is central pontine myelinolysis. Often these patients will have extrapontine pathology as well, for example, Parkinsonian symptoms, but usually they'll have CPM. The rates of correction are important, although it can occur at accepted rates. The level of hyponatremia, most of us feel that at greater than 120, you're less likely to get osmotic demyelination. I do worry, though, about somebody that has some of these other risk factors, such as hypokalemia. The hypokalemia has a role in genesis of hyponatremia due to exchange of sodium. And you can have an increase in sodium after you K-replete these patients, but there may also be potential CNS effects. Alcoholism is a big issue. Malnutrition is a big issue. Liver failure and liver transplantation. I've had malpractice cases I was involved in as an expert witness where someone developed ODS after rapid correction after a liver transplant. This is partially because you get similar changes in cerebral osmolytes in liver disease, and that compounds the risk of osmotic demyelination. In terms of the pathophysiology, you get a disruption of the blood-brain barrier when you overcorrect. You get leakage of antibodies, complement, cytokines, and other immunological factors into perivascular brain. It's thought that the delayed induction of osmolyte transporters after correction of hyponatremia results in a decrease in osmoregulatory capacity and leads to cell swelling and death. There may be apoptotic or excitotoxic cell death after correction of hyponatremia. More recently, this asterisk paper is a lovely one showing that there's a defective glial proteostasis response and an unfolding protein response, an ER stress induced by correction. Many years ago, Rick Stearns did this study of patients who had rapid correction of sodium, who developed permanent sequelae and osmotic demyelination. More recently, contemporary studies have suggested that the incidence is much lower, perhaps because I think we're much more attuned to the disorder. but it does occur, and occasionally you don't want this to happen to your patient, and it does have an association with rapid correction. This paper from now 20 years ago was really important. It was a case control series of 122 consecutive asymptomatic hyponatremia patients who had variable sodiums, but they had a very high prevalence of falls. These were patients that had been seen in a medical ER, and the fall was often the reason for admission. They had subtle gait and attention deficits in a separate cohort of hyponatremia patients who were studied when they were hyponatremic and then when they corrected. And the falls didn't seem to have any dose relationship with hyponatremia. And there are other papers that suggest an association with fractures. And Joe Verbela showed a beautiful animal model of SIDH that's also associated with very low bone density. And there's an association epidemiologically with low bone density. So the patient that you're called to see who had a thiazide-associated hyponatremia and comes in with a fracture, that may have played several roles in the hyponatremia in that fracture, in that they may have had low bone density because of the chronic hyponatremia, and that may have been also why they fell. So treatment of hyponatremia, we'll talk a little bit about acute symptomatic hyponatremia. Chronic hyponatremia, it's tough to deal with it with fluid restriction unless it's a patient who has a moderate urinosum and you can sort of discern that they have an increase in fluid intake. Furosemide and salt tablets are effective but difficult to titrate. There's not a lot of good evidence that salt tablets are helpful with hyponatremia, but they tend to be used quite a lot in SIDH. Most of us don't use demeclocycline anymore. It's a tubular toxin that decreases the V2 receptor response. I use a lot of oral urea. The trademark is Urena. It's a palatable form of oral urea. You can get it in different forms through different sources, including on Amazon. And vasopressin antagonists are important as well. So the vasopressin antagonist, really the only one that I've seen available anymore is tolvaptan. It got a marked reduction in its use more than 10 years ago because of the increase in LFTs that were seen in the TEMPO PKD trial. So we do use it in PKD, but patients need to be on a REMS program. But generally, it's not used in liver disease anymore, and it's not usually used for more than 30 days. I do tend to use it in patients with severe heart failure-associated hyponatremia, but maybe 2 or 3 times a year at most. The papers that established this were a New England Journal paper that showed that tolvaptan is predictably helpful, and that response goes away once you stop the drug and people regain their hyponatremia. So as you'd expect, this was really attractive. Here's a drug that inhibits the hormone that causes this, and you can fix the hyponatremia. So the pros and cons, there are not that many indications anymore. As I said, I tend to use it for heart failure. They're not cheap. You have a risk of overcorrection. You can minimize by frequent monitoring of serum sodium. And you just need to tell this patient to switch gears and start drinking a lot of water when you start the Vaptan. We talked about the liver toxicity and my sense that it's mostly CHF-associated hyponatremia where I reach for this. There are many, many papers on oral urea. The hand waving is that oral urea is the opposite of low solute hyponatremia. You're giving an inert solute that helps you excrete water. This is a lovely paper from Belgium that showed you could take a patient on a Vaptan that had corrected, stop the drug, and then when you started oral urea, you got an equivalent response. So for acute hyponatremia, treatment can be life-saving. These patients need acute hypertonic saline. They need some measure of their oxygenation and their pulmonary edema. You do want to get CNS imaging, but you don't want to delay therapy. They should get a supplemental oxygen if necessary. Many patients like this get treated with loop diuretic. It's somebody in the ED, and they want us to give a drug to reduce the pulmonary edema. This lovely paper from the UK showed that a bolus of hypertonic saline is more acutely effective in increasing the sodium, but also reducing the neurological dysfunction that goes along with it. So marathons have hypertonic saline available at weigh stations and at the finish line, and will often give. I can also have point of care sodium testing sometimes, and they will generally give a bolus of 100 ml. So if I see somebody with acute hyponatremia where I'm worried that they're going to seize, I will give them a 100 ml bolus. And you want to correct them by 4 to 6 milliequivalents or until correction of the severe symptoms, and then the chronic criteria for within reason for overcorrection. So here we get into the thorny issue in chronic hyponatremia is what should the appropriate correction rate be? We know that if you correct by greater than 10 milliequivalents in the first 24 hours and greater than 18 in the first 48 hours, you can get osmotic demyelination. If you look at subsets of patients who get ODS despite being within these guidelines, many of them are hypokalemic or have other risk factors for ODS. Most experts advocate an even more conservative approach in patients at an increased risk of ODS, 4 to 6 milliequivalents the first 24 hours or so, and then no greater than 8 milliequivalents subsequent 24-hour periods. And I've definitely been involved with malpractice cases where the vulnerability seemed to be 3 to 4 days in for severe hyponatremia when there was a window where the sodium went up way too quickly in one 24-hour period. Luckily, though, now we can treat osmotic demyelination, and we can react to this by giving DDAVP and D5W to reinduce hyponatremia, and there's animal and human data. There's animal data that you can give back these osmolytes, myo-inositol, for example, or you can give dexamethasone to restore blood-brain barrier function, which we don't use clinically. Rick Stearns had this landmark paper in the late 2000s that showed that you could give DDAVP and safely reinduce hyponatremia, but you got this sort of herky-jerky up and down, which was very difficult to manage. He then had a subsequent case report and then several papers on what we call the DDAVP clamp, where you'll give vasopressin, DDAVP every 8 to 12 hours, and clamp the vasopressin activity as you dribble in sodium chloride. And my sense has been that this really has revolutionized our ability to correct serum sodium and do so in a controlled fashion, whatever rate that you think is appropriate. So we have another patient, a 40-year-old woman with a 1-week history of flu-like illness and profuse diarrhea. Again, this is a case that I had many years ago. She'd received 1.5 liters of saline, and I got sort of coincidentally called by the ED when she came in, and her urine sodium they had checked before the saline was 12 and a urinosum of 450. And then you could see as her urine sodium came up, she was starting to drop her urine osmolality, and she did start to overcorrect. So this was this was in the 2000s where it was a little bit nervous about giving DDAVP. But we can just sort of cut to the chase and say that DDAVP at some rate of a D5 is the appropriate management here if you've overcorrected. The causes of overcorrection can also be looked at as a differential. The classic one is hypovolemic hyponatremia after you volume resuscitate. Hypopit with secondary adrenal failure after you give cortisol and vasopressin comes way down. Thiazide-associated hyponatremia after discontinuation and saline hydration, or, and I should add to this list, in the setting of hypokalemia where you rapidly fix the hypokalemia and you get this sodium exchange and have an overcorrection. So we'll quickly go through in the last 5 minutes a little quick discussion of hypernatremia. Clearly, it's less of a concern for us as nephrologists than hyponatremia, but for completion's sake, I'll go through it. So you can either increase the numerator and develop hyponatremia or decrease the denominator, which is probably the more common cause of hypernatremia. Water disorders are very common in dementia patients and elderly patients where they have a blunted thirst response, or they can't get to water. High sodium intake without adequate water is very rare. Thirst osmoreceptor lesions are also pretty rare. And experimentally, some of the models of osmoreceptor physiology were done in sheep. And to develop a completely adipsic sheep, you had to lesion in the brain in many different centers. So simply hitting one osmoreceptor area did not cause the adipsia. You had to zap several areas. You can see that, though, in certain disorders. I have seen it most commonly in patients with neurosarcoid or occasionally with an infiltrating CNS tumor. Occasionally, you can see it with a stroke, or primary hyperaldo also does this. Elderly patients will have sort of a physiologic loss of their thirst response. But it's rare to see a completely adipsic patient. And when I've seen that, it's been in sarcoidosis. So you can have inappropriately high water losses that cause this and decrease your denominator. This is from sweat or breath. I learned this, in terms of, how sweaty I got during COVID when I would walk around with an N95 mask and was not exchanging heat, but also probably some degree of water when I was walking around with an N95 mask. Vomiting, gastric losses are usually hypotonic. Diarrhea, it's usually isotonic. If it's secretory, your sodium concentration together is about 140. You do get some free water loss with an osmotic diarrhea. And obviously, if you have a renal loss of free water with DI, you can decrease that denominator as well. Here, the differential is you have a decrease in AVP secretion in central DI. You can see an increased degradation of vasopressin in gestational DI. You can have renal AVP resistance, which is what we call nephrogenic DI. So central DI, you can see it after pituitary surgery, head trauma, again, granulomatous disease. There's some hereditary mutations in pre-pro vasopressin, or in Wolfram syndrome, you can see central DI. We're classically taught this triphasic response in terms of polyuria and then hyponatremia after pituitary surgery. But really, that triphasic response is not that common. If we have a case with polyuria, a urine output greater than 3 liters per day, the osmolar excretion rate is critical. So if it's greater than 1,000 milliosmoles per day, that's an osmotic diuresis. That can be from NaCl, glucose, urea, or mannitol. We had a case report that we published in AJKD several years ago of a patient with hereditary glycosuria who came in during pregnancy with massive polyuria because her sugar production, her glucose production had gone up during pregnancy. Less than 1,000 milliosmoles per day, that's a water diuresis. It can serum sodium greater than 140, you worry about diabetes insipidus. If it's less than 140, you worry about polydipsia. So causes of a nephrogenic DI, I mentioned the nephrogenic SIDH, which is due to an activating mutation in the V2 receptor. There are many, many different mutations that cause loss of function in the V2 receptor, which is X-linked. And that you'll pick up with a Renocyte panel if it's a coding mutation. There are autosomal recessive or dominant causes due to mutations in aquaporin 2. There's an autosomal recessive form, aquaporin 1. There's a lovely story about that, in that these patients or subjects were thought to have no phenotype except for a concern about red cell transfusion reactions because they don't have red cell aquaporin 1. But when the knockout mouse came back and had a nephrogenic DI, Peter Agre went back to these patients and showed that they did have a nephrogenic DI. Clearly, the most common cause that we see is lithium-associated nephrogenic DI. You can also see it in our hospital from ifosfamide. Hypokalemia induces nephrogenic DI, as does hypercalcemia through many mechanisms, but predominantly activation of the calcium-sensing receptor. And again, cellular defects, infiltrating lesions, or you can see it after resolution of acute tubular necrosis. Gestational DI is due to an increased expression or release activity of vasopressinase, which is produced by the placenta. This can occur in context of preeclampsia and or acute fatty liver or pregnancy. Just be aware that vasopressin levels go way up at the end of pregnancy, as does vasopressinase. And if you check a vasopressin level, because of the endogenous vasopressin in the sample, you'll get a negative result, although we now primarily look for copeptin levels. If you do a water deprivation test, and I still occasionally do this, as you deprive the patient of water very carefully with careful monitoring, you'll give vasopressin to look at the response, and you can subdivide it into partial central or nephrogenic DIs. Again, copeptin has become very important. Generally, you can't get vasopressin levels anymore. If the stimulated copeptin, either after a water restriction or after hypertonic saline, if it's less than 4.9, that suggests central DI. But if it's greater than that, that suggests primary polydipsia. And if it's greater than 20, that suggests nephrogenic DI. So treatment is to restore the water deficit and replace or reduce ongoing loss of hypotonic fluids. Very rarely do you treat the underlying cause, except in central DI when you're going to give DDAVP. You can use DDAVP in gestational DI because it's resistant to the vasopressinase. A key issue is that the rate of correction of hypernatremia in critically ill patients doesn't seem to affect survival. But generally, we try to reduce serum sodium by graded amounts per day. There are some quantitative formulas. The most important one really, well, both of these are important, just to get some idea of how much the water deficit is, but also to look at the electrolyte-free water clearance. And the classic error is somebody, say, with lithium-associated nephrogenic DI, where people forget that this patient is putting out several liters of excess free water per day, and you need to replace that on a daily basis as well as replace the deficit. So the take-home messages, I wanted to talk about central osmoreceptors and hyponatremia, the differential of acute hyponatremia and hyponatremia prone to overcorrection, the role of DDAVP plus D5W in patients who overcorrect. We talk a bit about the DDAVP clamp with hypertonic saline to provide controlled correction. We talked about the use of oral urea in SIDH. And for hypernatremic patients, don't forget that some of these patients have ongoing free water loss. It's not just your usual demented elderly patient where it's not ongoing free water loss, it's mostly a reduced intake.